Chapter 2: Healthcare in the UK and an alternative option. Healthcare worldwide is on the brink, and much of this is driven by staff shortages. A pandemic was long predicted, and the reality of it was brutal. More brutal than we could ever have imagined. We lost many colleagues, or even developed long COVID syndrome ourselves. Many colleagues in all areas of the hospital were broken by their experiences. Many felt they needed to be protected, and that necessary protection wasn't there. My relatively small hospital did a phenomenal job of having a steady supply of quality PPE, and it mattered. We felt seen and appreciated. They also provided free meals, which makes staff feel valued and appreciated. Post-pandemic, staff across healthcare should have been more respected. Instead, their efforts and sacrifices were forgotten or even erased. Demand since the pandemic has soared, and few staff have any juice left in their tank. Many developed countries were experiencing reduced resources, including staff, before the pandemic. This made staff already vulnerable. Society often sees the healthcare staff as being an amorphous body. Like any group, it's formed of many different individuals. Each one has a personal and professional circumstances that drive and sustain them. They also have unique and professional challenges that pull them down and also lift them up. That up and down balance changes over time, and often we rely on colleagues to buoy us in the hard times. I'm very fortunate to work in a great team. We support each other, and generally when one or two are having a short struggle, the rest will buoy them up. Those who are up or down naturally wax and wane over time. What though if more staff are down than up? What if we can't see our imposter syndrome? We miss the chance for individuals to regain their energy. We miss chances to pull them back from this abyss. Political opinion warning. The system might benefit from keeping medics right where we are, constantly questioning whether we are good enough. We fear sharing our concerns. We stay isolated. We are isolated in a sea of others who likely suffer the same as ourselves. The irony is that as a group, we are some of the brightest, bravest, most resilient and innovative folks out there. Doctors are leaving in droves. Financial benefits funnel to hospitals, insurance management and administration rather than clinicians, certainly in the USA. As many doctors leave healthcare following burnout or breakdown, our value is starting to be recognised. It's time we looked up and around and saw it for ourselves. Collectively, we have tremendous power. The recent junior doctor strikes in the UK have done quite a bit to show the public how junior doctors are treated poorly. They give so much, are treated so poorly, and now are even being edged out by staff less qualified than themselves. The new staff are even paid more. Some examples of this poor treatment include senior registrars feeling grateful to sit on a bin. There's no chair for them, and there are pictures available. Junior doctors having no computers to work. Then they're shouted at and constantly bleeped while the demands are exploding. No hot food available much of the day, or especially at night. Begging to get your own wedding day off, and then being rostered to work either that day or until midnight or 2 a.m. the night before. Some staff feel pressured, burnt out, or have personal issues. Many are often terrified of making an error or being exposed as inadequate. There has been a spate of suicides recently on Med Twitter, on X, formerly known as Twitter. This is tragic, and even worse, we should have appreciated these people more. How hard is it to treat those well who treat us as our most vulnerable? Those who seem the most caring and relaxed are often painfully insecure below the surface. This is because they've learned to put on an act constantly, but unfortunately, maintaining that act is exhausting. Having staff who are happier in themselves and have energy for both inside and outside work means they provide better care for patients. Imposter syndrome is the zeitgeist. There's a tsunami of imposter syndrome around us. We see courses at the deanery, school level, and for consultants and attendings. It's almost fashionable to admit you have it. Almost. And that's good. The barrier to talking about it is falling, and more support is becoming available. But there's still a long, long way to go. But just like eating an elephant one bite at a time, helping one person after another is a good start. And if others start to join in this work, that effect should multiply over time. Hopefully, employers will also see the value of such initiatives and start to invest in them. The bright ones will become early adopters. If you keep your clinicians, suddenly you'll be a magician. Less compassionate managers or supervisors may excel less in the pastoral elements. But selfishly, they can expect better performance and results from their staff or trainees. They may embrace it purely for their own results. This also means they may be open to funding treatment or seminars and lectures. It'll make them look good, and we all know how they like that. So long as the people who are suffering benefit, I'm still happy. Okay, what could be better? Stopping the endless pushing of resilience training and relaxation activities. The burden is on the sufferer to find the time when they're already exhausted, or to try and access it when it's impossible due to work demands. Or, even worse, mandatory attendance during precious breaks, meal breaks, or time out. Just stop it. If nothing else, let this book save us from that. These therapies are no secret. You could train to do them too. Most of us here have a healthcare foundation at some level. That might be medical or nursing, or in an allied profession. You have a sound therapeutic foundation already. Why shouldn't you take on doing therapy for others? Once you've been helped yourself, of course. You can then become the best advert for good therapy. Adding these two therapies to your repertoire can transform your clinical practice. You might deliver therapy alongside your medical practice, separate sessions for patients, colleagues, or other professionals. There are hundreds of untapped niches out there. You might develop therapy as a strand in your exit plan from your current role. A few years ago, the term exit plan was for eccentrics, or those who might have been deemed weak. Gradually, more and more people have been open about discussing plans, so the concept has grown alongside portfolio careers. Full-on clinical roles are becoming increasingly unsustainable, and we're all starting to recognise that. In the past, we saw ourselves as dedicated to the one system. It was a vocation. And it still is a vocation. Like many of you, I still love the work. I love working with patients. But I wish there were less intensity. I wish the system were more flexible. I wish there was less admin burden. In the US, I'm sure that's true 100-fold. At least in the UK, we rarely need further approval or insurance involvement. The respect for healthcare staff has also declined exponentially over recent years. We saw this in the pandemic. Our opinions were minimised. Our needs were ignored or dismissed. More than anything, that has strained the vocation and dedication for most of us. Loss of autonomy, relegation to numbers on a spreadsheet, and plummeting in real terms remuneration in the face of relentlessly climbing workload broke some of our strong bonds to the system. It didn't, though, break our bond with patients. But things can change for the better, and often these changes are abrupt after a difficult period, so don't lose hope. As fewer hours remain and the exodus continues, our skills will become appreciated again. Adding more and more staff trained differently who can't act autonomously, or new types of staff with less training and experience isn't helping. It won't work, and that reality as delivered currently is beginning to be recognised. Plugging gaps with staff who can't act autonomously isn't replacing like for like. Some studies suggest that GPs complete 4 to 5 times more clinical encounters than some of these other roles. This may eventually lead to doctors only getting the most complex patients, which can be very stressful, while also needing to supervise many others seeing the less complex patients. How many will stay in a system that works that way? Meanwhile, it's okay to want a portfolio career. It's okay to develop an exit plan. It's better to start planning now than start from scratch after a sudden resignation when it all became too much. Many of us teeter on the burnout and breakdown abyss, but it remains invisible until we fall. Let's work on stepping back. We can also step away or to the side if these feel right for us.